As we went through the second part of the survey, we really found how the interaction, a disruptive interaction, would lead to a highly stressed individual, people who couldn't concentrate, they couldn't focus on their task, they became intimidated, they didn't want to talk to the doctor, which meant that vital information would not get exchanged. Things to know about the patient wasn't passed on. It affected collaboration and communication. And then we saw the serious incidents of adverse events, quality problems, safety problems, and even inpatient mortality. So behind that objective data, we actually had a comment section on what did you think would be going on. And this really gave an opportunity for some of the respondents to really talk about issues about how they were so afraid to call somebody, or they would call somebody, they wouldn't listen to them, and they would do something else. And even when the patient was having a change in clinical status, they couldn't get the physician to really address the issue at hand. And in some cases, the patient either had a serious medical event, or even in some cases, the patient actually died.
I think that the reason disruptive behavior can have an adverse impact on patients' experiences through a variety of ways. One example is that patients, whether they're in a critical care unit or on a regular unit, are very aware of what is happening on a unit. They can hear what's being said, they know whether or not teams of people are getting along well. I think because they're so vulnerable and in a crisis as a patient, they're hypersensitive to the emotions that are going on around them. They know whether we're present for them. And disruptive behavior creates an environment where people are afraid. People may not want to communicate something for fear that they're not going to be heard, that they might upset someone. And I think that that's the biggest issue around disruptive behavior, is that if it's allowed to go on, then it's, I always tell staff, people behave in ways that work for them. And if someone is not held accountable to perform or behave in another way that's more acceptable, they'll continue to behave in that way. And that negative disruptive pattern influences the whole team.
The themes were, one is that disruptive behavior is very prevalent, and it's not so much the physical abuse, it's really the yelling, the disrespectful, condescending behavior that was really affecting the recipient. So that was one theme. Another theme that came out was, we have a disruptive behavior policy, but every time we report, it goes into a black hole. Or we report, if a nurse would have done this, they were fired, but if a physician did this, they looked the other way. So we found that a frequent occurrence of disruptive behavior, and even if you had a reporting policy, it wasn't very effective. And then the third thing we found is we know what's going on, but we're not sure how to handle it.
The personal impact is that really it diminishes people. And it can create a loss of confidence and really a kind of a professional crisis, because the stress response to this kind of treatment in the workplace is to leave, is to run out the door. People can't always leave because the positions are not available, or jobs are not, as well paying as what we pay in our institution or whatever. So it really creates a crisis of confidence and a crisis in the career of the person. And sometimes bringing up the issue also creates its own ripples. So it's really a matter of judgment and a way of handling situations in a delicate way, and with just the right amount of input and discussion, and not escalating the conflict.
When we started doing research on nursing disruptive behavior, one, we found out it's as frequent as physician disruptive behavior and other disciplines, pharmacy, laboratory, respiratory therapy, physical therapy. They all have disruptive individuals. What we found with the nursing, it's more what's called horizontal hostility. It's not overt, it's more passive aggressive, and it's that constant undermining and almost subterfuge where you're really getting to make things negative out of something and you don't know where you stand. And that's a much more serious issue because you don't know what the downstream effect is going to be.
I see everyone working and everyone contributing to a system so that changes can be made and that conflict can be managed, that disruptive behavior, that we see less of it, and that we can really focus on what we're all there about. And what we're there for is really the patient and ensuring quality of care and patient safety.